Good morning, ladies and gentlemen. Thank you for the kind introduction, sir. And I thank College of Ophthalmologists for giving me this opportunity. I'm going to talk about glaucoma. It's going to be an overview of glaucoma. Glaucoma is a different, entirely different subspecialty nowadays. So what I'm going to do within this half an hour is I'll be discussing briefly about the anatomy, pathophysiology, and investigations and some mode of treatment of glaucoma. Right, so why glaucoma is so important? Because it's one of the leading cause of blindness worldwide, and it is also called as a silent killer of vision, because most of the time, the glaucoma patients, they are asymptomatic. They don't know what's going on until it's too late. And it's when they found out the vision is affected, we can't, there's little that we can do. So it's important that we find out these patients early and treat in the very early stages so that we can control the disease. So your role in glaucoma is you're the initial point of contact in ophthalmology care. And so you will be the first person when most of the people are visiting. So it could be, as I said, we had to pick these patients. We had to find these patients because they don't come and say that they are having a problem. So when they come to a different reason, even in the hospital, even in our clinic, we detect 90% of glaucoma patients are detected when they come for a different reason. It could be diabetic retinopathy, diabetic screening, it could be cataract, it could be a trauma. So 90% of them are diagnosed when they presented with a different problem. So when they come to you, they come, as I said, they come to you for reduced vision, for glasses, changing glasses, right? So when they come to you, you have to have an eye, just make sure that this patient doesn't have glaucoma. Any person over 40 years, you have to check the optic disc and make sure the discs are fine. And if you have the facility, better do check the eye pressure as well. And now family history has a major, when it comes to causes of glaucoma, you can't give exactly, it's a, what we call is, it's a multifactorial disease. Many factors come into play. We can't point out and say this one particular reason for glaucoma. So, but family history plays a major role. So, when you talk to the patient, just, in your checklist, make sure, just ask whether any family members is having glaucoma, or are they taking any glaucoma drops. And awareness is more important. Now, this, March is the glaucoma month, and so we have been conducting, World Ophthalmology Congress and the Glaucoma Congress. They have identified the main mode of fighting with glaucoma is making the community aware about the disease. So, because if you can't, we can do eye camps and screening programs, we can catch 100 or 2,000, 100 or 500 patients and screen them, but that's not going to be the way forward. You have to educate the entire community. They have to be aware about the disease and the impact of disease. Then only they will come and get their eyes checked. So make them aware about this condition. So in my just to give an outline of my talk, I'll be briefly discussing about the anatomy of the drainage angle and the types of glaucoma, and briefly about pathophysiology, and more importantly about the symptoms and signs of the disease, and bit of investigations and a little bit about treatment as well. So if you can remember the anatomy. Yeah. So this is the cornea, and this is the pupillary plane made by iris, and between the lens and the cornea you find this anterior chamber. This is the anterior chamber, and this chamber is filled with a transparent liquid called aqueous humor. So aqueous is produced in these areas, ciliary body, and it travels through the pupil to the anterior chamber, and then it absorbs through this area in the drainage angle, right? This is another diagram. So the ciliary body, this is the ciliary body. So the aqueous is produced here, and then it transported through the pupil into the anterior chamber, and then it drains to the trabecular measure here in the drainage angle. So this is a rough sketch diagram of the drainage angle. So you can see the drainage angle is located between the cornea and the iris, right? So I'll be discussing about open angles and closed angles later. So this is where the drainage angle lies. So this area is very important when you're talking about in glaucoma, because this is if this area gets blocked, the pressure, the drainage is obstructed, so the eye pressure can go up. So classification, this is going to be a brief classification. So you can classify glaucoma as primary glaucoma, and then childhood glaucoma or congenital glaucoma, and then the secondary glaucomas. So primary glaucoma means there's no there's no other reason for patients getting glaucoma. Just patient, that's how he born it. The genetics and environmental factors, everything comes into play, and no special reason can point out to get him to get this disease. Childhood glaucoma is a different entity. They are the very newborns and infants. We have categorized it as a different entity because the management is slightly different, and the disease progression is also different. It's a kind of aggressive disease which you have to aggressively treat. Most of the time medical treatment fails, so we have to go and do surgeries on these kids. Secondary glaucomas, as the name suggests, is secondary to something else. It can be trauma, it can be prolonged inflammation of the eye. It can be secondary surgery. Sometimes patients get glaucoma after cataract surgery or following vitreoretinal surgery. So it's secondary, as the name suggests, it's secondary to something else. So these are some pictures of congenital glaucoma. Now, these babies, they are having large eyes. We call it buphtalmos, bull-like eyes. Now, babies anyway have large eyes, but now these buphtalmic eyes are disproportionately large. Sometimes the patients, the mothers, they complain that the child is tearing. So sometimes we tend to neglect this symptom, because most of the time, if a infant is tearing, we label him as nasolacrimal duct has not developed. So this is probably because of the underdeveloped nasolacrimal duct. So we label him as obstructed nasolacrimal duct, and then we ask the mother to massage the eye, and then we leave him to a side. If it's in congenital glaucoma, they also get this tearing. So if it's glaucoma, the pressures, these kids' pressures are very high. They have to treat immediately. They need aggressive treatment. If not, within months, they get blind. So any kid, a kid could be infant or a bigger child. If they are complaining of watering of eye, make sure to have a look at the optic disc and to have a pressure check if the facilities are available, because it can be glaucoma, and don't let it undiagnosed. So in this kid, now the both eyes are ophthalmic, both eyes are large, and you can see the cornea are wide. So the corneal diameter is large. In this kid, only one eye is large, so the other eye looks fine. So sometimes if the pressure is very high, they get corneal edema and they get white eye like this, because this is because of the corneal edema. So secondary glaucoma, as I said, as the name suggests, secondary something else. It can be blunt trauma leading to hyphema. This is hyphema, blood in the anterior chamber. So this blood could be secondary to trauma. So this blood can block the drainage angle and ultimately leading to high eye pressure. This is hypermature cataract, phacolytic glaucoma. So what happens is, in my area, in Polonnaruwa, we get a lot of patients like this, because what happens is, if they are having cataract in both eyes, they will present to a eye clinic, and they will get the eyes checked, and if there is cataract, they will get the cataract surgery. And now one eye is good, he can carry on with his work, so they tend to neglect the other eye. And then other eye the cataracts get mature, and it's become hypermature. And then once the cataract is hypermature, this lens material, they diffuse out, and these are proteinous materials. They block the drainage angle, and then they end up in a very disastrous conditions called phacolytic glaucoma, very difficult to treat. If they present in time, we can get rid of the cataract, and we can sort it out. But if it's too late, well, then we can't restore the vision. This is a condition called pseudo exfoliation syndrome. So again, quite common in Sri Lanka. So they get this powder-like stuff, substances in anterior chamber and over the pupillary margin. So that is that these membranes, these substances also block the trabecular meshes and lead into high eye pressure. So secondary glaucoma, there are a number of causes. I just discussed briefly some of the more common ones. So primary glaucoma, as I mentioned, 90% of glaucoma are 80 to 90% of them are primary glaucomas. So as again, this is a slide just to recapitulate the anatomy. So the aqueous humor is produced in the ciliary body area, and then it travels through the iris to the anterior chamber and absorbed in this trabecular meshwork area. So primary glaucoma we classify again into open angle and closed angle glaucoma. So this is the difference. So in primary open angle glaucoma, this drainage angle is open, widely open, whereas in closed angles, drainage angle is closed, if you can see, right? So when you examine the eye, when to suspect these patients. So when you see the patients, the angle closure glaucoma patients are having very shallow anterior chamber, right? So when you are refracting a patient, if you are getting high plus values, like if it's more than plus say 3, so always suspect of narrow angles, right? So sometimes when you are practicing, if you are practicing along with the eye surgeon, so you and eye surgeon will be dealing with the patients. So you'll be refracting, and then sometimes you'll be asked to dilate the patient straight away, and you'll be sending the patient to the eye surgeon. So if you are getting high plus values, like +4, +5, like that, so do not dilate them straight away, because they might be having closed angles, narrow angles. So if you dilate these patients, they will go into acute angle, a condition called acute angle closure glaucoma. This is happening. It's quite frequently happening. So when you practice in the hospital or outside, optometrists do a patient and do the visual acuity and refraction, and then they dilate and send the patient to you to us. So, when you see the patient, it's a very high plus refraction, and then patient can go into acute angle closure glaucoma, because now when you dilate the narrow angle patient, this eye is pushed towards the periphery, and it further block the drainage angle, and so the patient goes into a acute angle closure glaucoma, which is a very painful condition, and difficult. I mean, it's an ophthalmological emergency. So we have to avoid this by always suspect of narrow angles in high hypermetropia. Even if it's more than 4, always better to have ask the doctor to have a look before dilating the patient, right? Right. So, the pathophysiology, I'm not planning to go into detail. So, what happens in glaucoma is now high eye pressure is developed in this area, the front part of the eye, and it's transmitted towards the back. So, in the back, you get the optic nerve. So, because of this pressure, optic nerve blood supply get compromised, and the nerve gets damaged. It's going to be a slow damage. The patient will not notice the high eye pressure, because most of the time these pressures are not too high, most of the patients, because it's like 20 or 30, if at all 30s. So it's if the pressure is less than 40, patient would not notice it. So it's the pressure can go pressure can remain high for a considerably long period. So so that this pressure can keep damaging the optic nerve. So how does it damage? It damages from the periphery to center, right? So so again, this is another diagram to show the this shows the how the optic nerve blood supply get compromised in glaucoma. Right? So the signs and symptoms. So this is mostly, as I mentioned, mostly it's asymptomatic. Very rarely they can come with if they are in a acute angle closure episode, they can come with pain, redness, and headache. And if you check carefully, you will see the pupil is mid dilated. If they will come with eye pain, and maybe they're having red eye, and if you check the pupil, you can see a pupillary asymmetry. Affected eye is slightly dilated. So that this is a very minority of patients. They come with acute angle episode. This is a very minority, and their outcome is actually good, because they come early, we treat early, we can sort them out early. But the chronic glaucomas are not. They are not so fortunate like that. So they remain unnoticed for a long period, and their nerve damage is quite significant. So sometimes, in later stage, they can come with complaining of visual field defects. They can't see the periphery. Then it's too late. That's because of the peripheral visual field loss in advanced glaucomas. They are the people with tunnel vision. So this is how the field defects progress in glaucoma. So this is the normal vision, how a normal person see the world. And in early glaucoma, you can see the edges of the periphery. More the peripheral areas are get blurred. And when it's get advanced, when the disease is advancing, the field of vision is getting more narrower, and in the end stage, the patient is left with very tiny hole of tunnel vision. Even in this stage, they can have 6 visual acuity, right? The visual acuity can be 6. They will say that, doctor, I can see miles and miles ahead. But if they ask or close the other eye, and whether you can see the periphery, no, they can't see, right? So, and what happens is the pressure is high. This tiny tunnel is also going to get blurred soon, and then very soon he's going to be NPL vision. Okay. So that's the danger of glaucoma. So we have to pick patients in this area. Good if you can find them in this stage, at least these stages. So this is a picture of acute angle closure glaucoma. You can see the eye is red, watering, and if you can see carefully, now the pupil is average size here, but it's mid dilated in this eye. Right. So this is acute angle closure glaucoma. This is because of the acute sudden rise in eye pressure It's an ophthalmological emergency. You have to direct the patient straight away to the eye clinic. So intraocular pressure usually ranges between 10 and 21 mercury millimeters, and it measures its tonometer. So the gold standard way of measuring eye pressure is this way, is by this way. This is the Goldman applanation tonometer. We also call GAT, G-A-T, Goldman applanation tonometer. This is the gold standard way of measuring the eye pressure. But there are other ways of measuring eye pressure. Now this is an air puff tonometer, where you get ask the patient to sit here in front of this instruments, and you and the machine generate an air puff, and with the reflect of the with the velocity, the machine can get an idea about the eye pressure. And this is a newer eye care tonometer. So here again, it's a contact tonometer. It has a tiny probe. You don't have to anesthetize the eye because it's a very tiny probe. So it's hit the probe hit the cornea and reflects back. So so the machine calculate the eye pressure with the formula and gives you a pressure value. So these are, these are good for screening, and this is good for pediatric when checking. Sometimes in kids you can't get them into a slit lamp and check the eye pressure with the Goldman applanation tonometer. So if the patient cannot get to the slit lamp, like a kid or a bedridden patient, so these methods are important. Or else these tonometers can be used in screening patients outside the eye clinic. You can use these instruments to check the eye pressure. Right. So now again, just to capitulate, now we have discussed about the anatomy, and we discussed about the pathophysiology of disease, and that we discussed the types. And now we are discussing the signs and symptoms of the disease. Right. So when it comes to we discussed about the symptoms. When it comes to signs, so optic disc evaluation is very, very important in glaucoma identification, right? So if you can check the patient's eye with an ophthalmoscope, if you can make it a routine, even if the patient has a family history of glaucoma, try to check the eye with ophthalmoscope, right? So you have to be familiar with the technique. So if you are examining the patient's right eye, it has to be your right hand. You're holding the ophthalmoscope with your right hand. You'll be examining the patient with you'll be seeing the patient with your right hand. So everything is right. When it comes to left hand, patient left hand, your left hand, and ophthalmoscope in your left hand. So otherwise, you'll be going across the patient's face, and it'll be uncomfortable. So everything right in when you're examining the right eye. Okay. So when I don't have a video of this, but so direct the ophthalmoscope to the pupil. You can dilate them and have a look, or else get the red reflex and follow the red reflex, and then locate a blood vessel and follow the blood vessels to the optic disc. That's how you locate the optic disc, right? So patients should not be looking at the torch. So if they are looking at the ophthalmoscope, so you will the fovea is focused, so you will find it difficult to get the optic disc in the focus. So ask them not to look at the light. You have to look straight ahead, and again get the red reflex, and then follow the red reflex to the eye, towards the eye, and then locate a blood vessel, and then follow the blood vessels towards the optic disc, right? And then, so this is how normal person's how we see a normal fundus in ophthalmoscopy. So these are the blood vessels, and this is the optic disc, right? This is the macula and fovea. So what is cup disc ratio? So cup disc ratio is this. So disc is the entire diameter, cup is the smaller diameter in the middle, right? So between beyond the cup, you get this peripheral area. This is the neuroretinal rim. These are the nerve fibers, right? So in the cup area is bare. There's no nerve fibers in the cup area. So you get all the nerve fibers in the between the cup and the disc area. So what happens in glaucoma, as I mentioned, because of the high pressure, the nerve fibers gradually they die. So the cup enlarges. That's what we call cupping in glaucoma, right? So cup enlarge. Normally, cup disk ratio is about up to 4.4, but so in glaucoma, this cup disk ratio increases. It can be 0.6, 0.8, 0.95, right? So again, if you find now the cup disk ratio is more or less symmetrical in both eyes. If you find as asymmetry, like if one eye is 0.6, or one eye is 0.5, the other one is 0.7. So again, if the cup disk cup disk ratio asymmetry is more than, sorry about this, usually said to be, normally it's less than 0.2. If it's more than 0.2, you have to suspect of glaucoma, right? So cup disk ratio is more than 0.4, or the cup disk asymmetry less than 0.2, more than 0.2, you have to suspect of glaucoma, right? Right. So this is again a diagram. So this is a normal neuroretinal rim with a cup disk ratio of about 0.4, and this is what happens in glaucoma. This is optic disc cupping, so the cup increases, right? Again, these are some pictures. So normal healthy optic disc. This is early glaucoma, moderate glaucoma, about cup disk ratio about 0.7, and this is end stage glaucoma. You can see white because this is the advanced glaucoma, 0.9, 0.95 cupping, right? Gonioscopy. You must be familiar about this term. So we cannot visualize the drainage angle with the slit lamp examination straight away. So you have to use a lens called gonio lens to visualize the drainage angle, and this is how it looks like. So I'll briefly go through some of the investigations. Now, when it's come to glaucoma, we mainly talk about now in ophthalmology, unlike in other fields of medicine, we are having very less investigations, right? So when it's come to glaucoma, the main modes of investigating a patient is with the visual field test and OCT, optical coherence tomography. So optical coherence tomography, it uses infrared light to assess the thickness of the retinal nerve fiber layer. Right. So this is a OCT machine. You get the patient to sit like, keep the sit like this and keep the chin here, and then the operator get the things into focus, and you get the report like this. Right. This is a OCT RNFL report. Right. Retinal nerve fiber layer report. Right. So this side, the left side is normal, where you get red and green. Sorry, green is normal, and if you get red, it means thinning of the retinal nerve fiber layer. So visual field test, again another way of investigating these patients. So patient, this is a machine. Patient keeps a chin there, and the machine will flash a light in the peripheral field. So when he see the flash, he or she has to press the button here. So this is, this has a kind of a learning curve. So patient will not do it properly in the first few tests. So it takes time to get used to the machine. So first few reports will be unreliable, but it takes some time for the there's a bit of a learning curve. So when it's come to treatment, you have medical treatment with eye drops, and laser treatment and surgical treatment. So medical treatment are mainly with eye drops. We have a number of eye drops, but mainly we are using the most potent eye drops groups are beta blockers, timolol, and prostaglandin analogs. So what the drop technique? So now they might ask you about how now these glaucoma patients, they are going to be on drops for lifelong. So you have to advise them about the proper drop technique, right? So how to administer a drop. So one drop is adequate, because you can, sometimes they tend to put more than one drop, but within the eye there's only there's space only for one drop. Even if you put 2 or 3 drops, the rest of the drops will be, they will be, they will not remain in the eye. Only there's space only for one eye drop, right? So one drop is adequate. Otherwise, they will be wasting drops. These drops are very costly, so one drop is more than enough. So after the drop, you can evert the lid and put the drop. The patient can do it by, himself. And after the administering drop, they have to compress the tear duct area here, right? This is to minimize the systemic absorption. When someone put an eye drop to eye drop, it will ultimately goes to the, you can feel the bitter taste in the throat. That is because the drop through the tear duct, it travels to the nose, and we can feel it in the nasal mucosa. So from nasal mucosa, it gets absorbed into the bloodstream. So we have to avoid this, because these drops, when they are in lifelong eye drops, you have to avoid this. So for that, ask them to, once they put the drop, ask them to press here for 3 minutes, right? At least 2 minutes, right? So, and then this is to minimize the systemic absorption, and then do the other eye, right? And sometimes, these patients, they live alone and they have very poor vision. They can't do it. They can't see well, so they can't do it properly. So in that case, they have to lie down, right? Lie down, and they ask them to direct the drop towards the edge of the nose, right here, and then they can squeeze the bottle. So when you are lying down, and when the bottle is here, and then they squeeze, somehow the drop will land on the eye at the end. So they don't have to worry. If they can keep the tip of the bottle here and squeeze, and then it will ultimately end up in the eye, right? So that bit of adverse effects of the drop. So with beta blockers, they can cause worsening of asthma. So if patients come to you complaining that after eye drops they are having difficulty in breathing, direct them towards the doctor, so they will sort it out. They will give a different class of drug. And prostaglandin analogs, like this analog, these drugs are, they cause a lot of ocular irritation and redness, and long-term use cause sunken eyes, right? And they get long lashes. So in this picture you can see now this eye probably had underwent a surgery, and he's using only eye drops for this eye. So you can see the redness and the sunken appearance, right? So nowadays patients are more concerned about their cosmetics. If we diagnose a patient with glaucoma in young age, we usually don't start them on prostaglandin analogs. We use them on beta blocker or something else because of these these side effects, right? Because they are going to live with this for many years. So the laser treatment, again, there are nowadays in Western countries now and in Sri Lanka as well, there's a newer technique called selective laser trabeculoplasty. This can replace the eye drops. So this is a one-off treatment. So you treat it with the laser. You treat the eye with laser, so it facilitate the aqueous drainage. So this is a cost-effective method. The amount of money that you are going to spend on eye drops for 1 year is less than the procedure is cheaper than that. So it's cost-effective. So this is very popular in the Western countries. Now we have it in Sri Lanka as well. Unfortunately, at the moment, only in the private sector. But it's a cost-effective way. But this is not suitable for any type of glaucoma. It's not good for angle closure type. It is only good for the open angles. So it's a evolving field in Sri Lanka. So I'll rush this with the few surgical options we are having, because I'm almost out of time. Surgical options we are having, as I mentioned. So surgical treatments, there are entity called MIGS, minimal invasive glaucoma surgery, and trabeculectomy and glaucoma drainage devices. These are some of the surgical options we are having. So MIGS means minimal invasive glaucoma devices, quite popular in developed countries. Now we do these surgeries in Sri Lanka as well. So these are tiny devices we implant together with the cataract surgery. Most of the time cataract surgery, very occasionally we do it as standalone surgeries as well. We only implant the surgery. Most of the time we do it in combination with cataract surgery. So you get rid of the cataract and put a new lens, and then you implant one of these devices. As I said, these are very tiny implants. This is an eye stent. The size of the eye stent is, now this is the finger, this is a coin, and this is the eye stent. So you can see how tiny the stent is, and this is the tiniest prosthetic ever made so far, right? So usually we inject 2 of them. It doesn't take much time, it takes additionally about, if at all, 5 minutes. Very effective ways, but very costly. It costs about £1,000, so in rupees about 400 to 500,000 rupees. In future it will come, but in our hospitals we do improvise MIGS. Now we are a bankrupt country, so we can't afford for these hi-fi gadgets. So we have improvised these techniques to our patients. So we are delivering a similar, with modifying our techniques. We perform kind of surgeries, and we also get the same effects. So the filtration surgeries, having trabeculectomy and glaucoma drainage devices. So these are some of the drainage devices. Some are costly. Now, if trabeculectomy fails, we implant these drainage devices. Some are costly, but then some of the surgeries are very invasive surgeries. So these surgical methods are reserved for the very advanced and if the medically refractive cases. So thank you.